Hi, I'm Rebecca Starkey, and I'm a midwife here in Central Florida. And I am really excited and really grateful to be presenting to you all on midwives in prenatal genetic counseling. It is a subject that is near and dear to my heart. I got a bachelor's degree in micro and molecular biology prior to becoming a midwife, and it is a subject that has continued to be an important part of who I am as a midwife. And if you're here, you have taken our survey, and I want to thank you for that. Also, I want to thank Kimberly Skellington, who is here with us today presenting on this subject. She is a subject matter expert. She is a board certified and licensed genetic counselor who specializes in reproduction, and she previously worked in prenatal as a prenatal genetic counselor with maternal fetal medicine, and recently transitioned to the preconception world where she discusses prenatal pre-implantation genetic testing for embryos. So she has agreed to share all of her knowledge and hopefully help us along in learning about some genetic counseling information and risk communication strategies that we can use in our clinical lives.
Right. Thank you so much for that introduction. I am very, very excited to be here, and thank you for allowing me to be the one to present so we can get right into it. So today the goals are to talk about the types of tests that are available, particularly screening tests as well as diagnostic testing options, talk about the conditions that we're even assessing for, touch base on the utility of a family history intake, as well as touch base on the collaborative roles that we all work together with in the prenatal setting, because we definitely do not do it alone. And so to start us all off, we will be talking about screening for aneuploidy. So there are a lot of different screening options, diagnostic options, certainly unique patients and patient populations. So it's challenging to really know exactly what should be offered to who. So there have been multiple organizations that have put forth some recommendations as to how to navigate all of this. And one organization that is kind of the hallmark is American College of OBGYN. So they put out a committee opinion every so often, kind of updating what should be considered for patients in regards to screening and diagnostic options. And so the latest publishment was done back in October of 2020. At which point it is now recommended that any patient, regardless of age or risk for chromosomal abnormality, should be offered all options. So this would include genetic screening, whether that is cell-free DNA screening or multiple marker screening, as well as diagnostic options. And so before we get into the specifics of what testing options are available, it's helpful just to remember and think about the conditions that we're assessing for. So the conditions of Down syndrome, Edwards syndrome, Patau syndrome, sex chromosome aneuploidies, select microdeletions, and neural tube defects are generally the ones that are being evaluated with screens. And the reason why these particular chromosomal aneuploidies are being assessed is because these are the ones that we're seeing ongoing pregnancies for. So most other chromosomal aneuploidies that are present in a conception, they may result in implantation failure or early miscarriages. So we don't generally see ongoing pregnancies. That's not to say that's not possible, but it's not something that we're generally seeing. As well as these are the most common chromosomal abnormalities that are being reported. And so just very quickly, everyone may be already familiar, but when we're thinking about someone with Down syndrome, some of the features that we expect to see would be some level of intellectual disability, distinct facial features, shorter stature, as well as the risk for certain birth defects, particularly heart defects. For trisomy 18 and trisomy 13, these conditions are usually described as life-limiting because they are. A lot of times we see babies pass away in the prenatal period as well as shortly after birth. However, there are some children who do live with these conditions, but they are experiencing intellectual disability as well as the impact of those birth defects. Sex chromosome aneuploidies are ones where some providers or clinics may not want to offer this necessarily to patients, or patients may not necessarily want to know this information. And the reason behind that is because generally for a sex chromosome aneuploidy, this is not, or these are not conditions that necessarily would cause intellectual disability or severe birth defects. They may be viewed as more mild. And so maybe it's something that some people are not necessarily interested in learning about for their future child. However, there are still some features and impacts that can occur secondary to having a sex chromosome aneuploidy, so it still can be valuable information for a patient. Microdeletions, so there are definitely quite a few different ones that are out there, but on average, we do see things such as learning disabilities or intellectual disability. And then with neural tube defects, so that is the one condition that is not necessarily caused by a chromosomal abnormality. So neural tube defects can be, but they also can be caused by many other factors. But what a neural tube defect is a lesion, in the spinal area. So there's actually an opening. And so this can cause, various disabilities, kind of depending on where that lesion is located. And so with all of those conditions, we have many different options in terms of how those conditions can be assessed and which conditions are being assessed. So a way to approach the screening that is available is to kind of think about the screens in two main categories. So the first category would be the non-invasive prenatal screening, or NIPS, which is also referred to as non-invasive prenatal testing, or NIPT, also referred to as cell-free DNA screening. So all of those names are regarding the same test, and this test is evaluating placental DNA found in a pregnant person's bloodstream. And this analysis is able to produce results or risk figures for Down syndrome, trisomy 18, the sex chromosome aneuploidies, trisomy 13, and select microdeletions. The other category of testing would be multiple marker screening or maternal serum screening. And so those are the other three that are listed in this graph here. And so for these, some of the main differences are when these tests are being performed. So obviously for the first trimester screen, that is done in the first trimester. Second trimester screening is done in the second trimester. So that would include your quad screen or penta screen. And then you have the combination testing, which would be the integrated screen, sequential screening, and contingent screen. So all of these multiple marker screenings, they have various detection rates, various analytes that are being assessed, as well as various timelines or timeframes at which they can be performed. So certainly can be a little challenging as to identify what makes the most sense for a patient, but we have all of these options that are available. So it's important to kind of know what the pros and cons of each of those are. And so that's what this graph is trying to illustrate, of some of those differences of these types of screens that are available. Now, given that the cell-free DNA screen is a relatively newer screen to be available for testing, I did want to go into a little bit more detail about the methodology of this testing, which will also help to talk more about some of its limitations and other considerations. So the most common methodology of cell-free DNA screening is represented from this picture here. So as you see in that blood tube, there is maternal cell-free DNA. So quite literally, it's DNA that is not contained within a cell, but there's also DNA that's coming from the placenta. I know this chart or this picture shows fetal DNA, but technically it's DNA that's from the placenta. And how that is found in the bloodstream is that a very normal process is cell apoptosis of those cells from the placenta. And so when those cells apoptose, all of those contents are kind of spilling into the maternal blood in a way. And so that's where the DNA can be found. And this DNA, they come in fragments. So these fragments are about 150 to 200 base pairs long. And what labs are able to do are take those fragments and actually sequence them. And with chromosomes, each chromosome has a different set of genes that are on the chromosome, so they have unique sequences. And so the lab is able to say, okay, this fragment of DNA is coming from this particular chromosome, given these unique sequences that are being identified. And so they're able to match those fragments to chromosomes and do a counting method. And so the counting method is based out of the knowledge that for every chromosome, there should be a certain percentage of fragments coming from it or representing that chromosome, given chromosomes are of different sizes. So chromosome 1 is the largest chromosome that we have as humans. And so when you're looking at DNA, you should be seeing about 8% of that DNA or those fragments that are coming from chromosome 1, given its size. versus chromosome 21 being much, much smaller than chromosome number 1, not as much of that DNA should be present in that sample. And so if there is more DNA expected in the sample, then that indicates that there's a possibility of like a trisomy such as Down syndrome or trisomy 18, or sometimes even monosomy, so like a missing chromosome such as the case for Turner syndrome. So it's all of these proportions that are being compared in order to give these results. There is one lab that does use a different methodology rather than the one that I just described, which most other labs are utilizing. So this other lab is using something called a SNP-based methodology, also very helpful in situations of triploidy. So triploidy is a chromosomal abnormality where there's actually an extra chromosome for every single pair. So that's something that this technology would be able to pick up, whereas the other methodology would not. So with all of this screening, there's so many options, so many pros and cons to each of them. So it is very challenging to really know what makes the most sense for your patient or patient population. So how do you decide which test to offer? Because it would be extremely cumbersome to offer a patient all of those and make them decide which one to use. So a lot of times, providers kind of have a few options that they think makes the most sense for their population and maybe offer patients one or two of those options instead of all of the ones that have been described. So one easy way to determine what makes the most sense for a patient is where she is or where the person is in their gestational age, because that is one major difference, particularly with those multiple marker screens, is that they have very finite timelines as to when they can be performed. Other considerations can be for insurance. So what is the cost to a patient? Unfortunately, given the new ACOG recommendations, insurances will probably very soon start covering cell-free DNA screening to patients who are considered lower risk. So those who are younger than 35. And so that's something that, hopefully insurance shouldn't be too much of a consideration moving forward, but still is one way to try and identify what screen makes the most sense for patients, as well as patient compliance. So with the combined screens, these are ones that require 2 blood draws. And so it's really important to know whether a patient's going to be able to come back for that second blood draw in the second trimester. If a patient's having difficulty with traveling or if they are planning to actually move to another state, that testing really may not be feasible for them. Another way to identify or determine what makes the most sense in terms of your patient population is to look at the numbers. And that's definitely, again, the theme of these presentations are really to go into more detail about risk assessment. So that can be one way to identify what screen makes the most sense for your patient population. So this graph right here is to illustrate a point or maybe a reason why you might consider offering cell-free DNA screening to that lower risk patient population. Now that is the recommendation based on ACOG, and it's kind of because of this one particular reason. So as you see in this graph here, I've highlighted a woman who's in her 20 and a woman who's in her 35 years of age or pregnant person. And then what this graph shows is the incidence of those particular conditions that are listed at the top. And what's to be focused on is for microdeletions, the incidence for those are the same regardless of a woman's age. And the reason for that is because of how a microdeletion occurs. They're not really thought to occur secondary to non-disjunction, whereas the other chromosomal conditions are. So a microdeletion, the risk for that is the same for a woman regardless of her age. And so historically, in this setting, in the prenatal setting, when a woman's over 35, we start to put her in this high risk category or this higher risk category to have a baby with Down syndrome. And so that risk is quoted to be about 1 in 290. And so she's kind of regarded differently. She's offered, cell-free DNA screening. She's offered amniocentesis, maybe a little bit more so than a patient who is younger than 35. But if you look here, the risk for a woman who's 35 to have a baby with Down syndrome, it's really the same, almost the same risk that everyone has to have a baby with a microdeletion. So a woman who's 20, has that same 1 in 270 risk to have a baby with a microdeletion. And so because cell-free DNA screening can assess for microdeletions, For that reason, maybe she should be offered that to assess for that risk for microdeletions. Because in the past, it was regarded that a woman, if her risk to have a baby with Down syndrome is 1 in 290, that's considered a high risk. And so she should be provided these additional testing options. So that is kind of one argument to use cell-free DNA screening in this lower risk population because of that chance of a microdeletion, and that cell-free DNA screening is the only screen that can actually assess for microdeletions at this time. However, always to be most complete, you can kind of also then argue some of the reasons not to consider cell-free DNA screening for a low-risk population. So this is another graph coming from ACOG as well, where they are talking about each condition, kind of someone's age and what their age-related risk is for that condition. So really I want to focus on kind of the lines that are regarding for trisomy 21 or Down syndrome. So what this graph is illustrating is that for the positive predictive value, so the PPV value, this does change based on a woman's age, primarily because of her age-related risk. So it is not as likely for a woman who is 20 to have a baby that has Down syndrome compared to a woman who is 40. And that's reflected in the positive predictive value. The positive predictive value is essentially, if someone gets a positive result, what is the chance that that positive result is truly a positive result? So it integrates incidence to create that number. So for example, a woman who's 20, if she gets a positive cell-free DNA screen for Down syndrome, her positive predictive value can be from 38 to 80%. So let's just, for the sake of simplicity, use 50% for that positive predictive value. So that is essentially saying that this woman who's 20, the chance that her positive result is truly a positive result is a 50% chance. And so she will have to make a decision on whether she wants to proceed with an amniocentesis based on that 50% number, which can be a little challenging to really kind of know whether or not to proceed with amniocentesis that has inherent risks associated to it. Of course, kind of weighing some of her motivations and what information she needs at what point. But again, it just kind of can be challenging to know what to do with that kind of number, like a 38% chance. However, for a woman who is 40 and who has a positive blood test or cell-free DNA screen for Down syndrome, her positive predictive value could be quoted as high as 99%. So it's a little bit more clear when someone has a chance that their positive result is 99%, that it could be positive, to really say, okay, maybe diagnostic testing in the pregnancy period can be most helpful to really know for certain whether this is truly a positive result or not. One thing that makes offering cell-free DNA screening for women who are over 35 easier is just these numbers here that I'm about to present to you. So whereas it's a little bit more challenging to know, how helpful is it in the low-risk population, it's a little bit more clearly helpful in those who are in that higher risk population, such as older than 35. So this is a result from one of my patients where she had a positive quad screen for Down syndrome. And she was 35 at the time that this was done. Now, someone who is 35, her risk is roughly 1 in 236, as shown in this box on this picture. And so with Quest, their cutoff is actually 1 in 270. So a woman who's 35, her a priori risk, her age-related risk is already greater than that of the cutoff that is used for this screening. And so her results are expected to be positive given just her age-related risk. And so for a patient, how helpful is it to them to receive a positive result that was known to be positive from the beginning given her age-related risk? One could argue that it could be just more anxiety-producing, if anything. Now, this particular result did increase her odds a little bit more in that the risk came back as 1 in 52. But again, we just expected that result to be positive kind of regardless because of her age-related risk that was already greater than that of the cutoff. So really for someone who's 35, really what's most helpful, has the highest utility, would be that cell-free DNA screen because of what's being assessed, the detection rates, and that, just her age-related risk doesn't guarantee that that result would be positive. It's something that's actually assessing for the placental DNA. And this patient of mine actually did have her cell-free DNA screen performed. It was through the Prenatal test or product. It did come back negative, which was very reassuring. Unfortunately, in this case, actually her quad screen was ordered after the fact. So her NIPT or cell-free DNA screen was ordered in June and her quad screen was ordered in July. So she was somebody who experienced a negative result, so a reassuring result, but then had to go through feeling what it feels like to get a positive result with that quad screen. So it was really something to really go into more depth about these risks and kind of what was going to be expected regardless, that was going to be a positive result. So really kind of talking her through that so that she could feel a little bit more comfortable with her initial negative results. Because truly with the cell-free DNA screening, given the detection rate is 99% for Down syndrome, that one does take precedence over the quad screen. It's very likely that quad screen was only ordered because it was actually trying to be ordered as MSAFP only. So again, with the cell-free DNA screen, it is not assessing for neural tube defects. So it is still important to offer that maternal serum AFP analysis, which I think is what was intended to be ordered for this patient, and just accidentally it was ended up ordered as a quad screen. So as with every test that's out there, there are absolutely limitations to cell-free DNA testing. So again, since this is a relatively newer test that's been offered within the last maybe 10 years or so, it's important to remember that this is something that can have false positives as well as false negatives. And so it should still be confirmed with diagnostic testing, whether that's done in the prenatal period or after birth, particularly for those positive results. And a reason for some positive results is because, number one, what's really being assessed is actually placental DNA. So most of the time, the placental DNA and the baby's DNA are going to be the same in that they all originate from the same conception. So all of those cells and the chromosomes should be the same, but there are times where they're not. And that would be called placental mosaicism, where the abnormality may be just located in the placenta and it's not present for the baby. And that's one possible explanation why someone may get a false positive cell-free DNA screen and their baby actually does not have the condition. So kind of emphasizing why really this is still considered a screening test. The other limitation of cell-free DNA screening is that while it can say that it's positive or increases the possibility of one of those conditions it assesses for, it really cannot say how that condition arose. So for example, Down syndrome, most often Down syndrome is caused by non-disjunction, so quite literally just an extra chromosome 21, which in terms of reoccurrence risks, there would be a slight increased chance for that woman to have another pregnancy with Down syndrome, but that number would be substantially different had that extra chromosomal material come from an unbalanced rearrangement that maybe the patient actually carries the balanced version of the rearrangement. Reoccurrence risks may be much higher. So cell-free DNA testing cannot give us that information. Other considerations that some may consider limitations of cell-free DNA screening is that sometimes there are non-reportable or indeterminate results because they're looking at DNA and sometimes there are things that are revealed that maybe science technology just isn't familiar with just yet. So there can definitely be some challenges with some of those kinds of results that can come back. One of the most common reasons for those kinds of results, such as a non-reportable, is actually due to low fetal fraction, which means that there's not much of that placental DNA found in the pregnant person's bloodstream. So the lab is unable to provide a result with either none of that placental DNA or a little amount of it. And this is usually due to maybe too early of a gestational age. So if the patient had testing done when she was 8 weeks pregnant, this testing is not validated for that early of pregnancy, or if a patient has a high BMI, or if maybe there's actually a fetal aneuploidy present, sometimes could be the reason why there's low fetal fraction. Other things that can come up with cell-free DNA screening are incidental findings, particularly maternal malignancy or maternal aneuploidy. So of course, these things do not come up often, but they are a possibility. And there have been quite a few times that for my patients, they've been suggested to have an aneuploidy themselves. So this is actually a result that I received for one of my patients where they were able to say that for most conditions, the baby was negative. However, for the microdeletions that were assessed, they came back as indeterminate. And the reason for that is because what they were looking at in the lab's perspective was that there's an overabundance of a deletion of chromosome 11, and they are predicting that the patient herself had that deletion. So now this comes up, and what's recommended is for the patient to do a microarray, get her chromosomes tested, and then also if she is positive and does have this deletion, well, that means her current pregnancy as well as future pregnancies have a 50% chance to also have this deletion. So this kind of opened up a door that maybe the patient wasn't really willing or wanted to go walking through, or maybe wasn't necessarily described to her as a possibility. So certainly with cell-free DNA testing, incidental findings are possible. The other kind of screening to mention as well would be carrier screening, so more blood testing of our patients. So carrier screening, again, with ACOG, there is a committee opinion that has been put forth to help try and navigate all the many options that are available in the world of carrier screening. Ultimately, the goals of carrier screening is trying to identify individuals and couples that may be carriers of autosomal recessive or X-linked conditions. This can somewhat be seen as preventative medicine, and the reason for that is because if you know if there's an increased risk a pregnancy could have a condition like cystic fibrosis, well, then there are reproductive options that can be chosen at that time. One of which could be diagnostic testing in pregnancy, but also testing of embryos. So through that pre-implantation genetic testing option, embryos can be screened for certain conditions, and then only embryos without that condition can be implanted in that woman or person who's planning to carry that pregnancy. However, it's very important to know that carrier screening does not replace newborn screening. So carrier screening is really only of the adults who help to conceive that pregnancy. It's never actually testing a baby directly. So it really just provides with risks and doesn't actually diagnose these conditions for a pregnancy or for a baby. So ACOG at this time has recommended that every woman have testing for spinal muscular atrophy, as well as cystic fibrosis, as well as a complete blood count. There are other conditions to include when certain things are met. So for example, hemoglobin electrophoresis, which is the test that can assess for hemoglobinopathies, particularly for like beta thalassemia or sickle cell disease. So this is offered when someone has had a low MCV value, or for individuals coming from certain ancestries. This hemoglobin electrophoresis is offered. For somebody coming from an Ashkenazi Jewish ancestry, there are a couple of conditions that are recommended to test for, given that they are a little bit more common in that population. And then for Fragile X carrier screening, this is recommended to be offered when there's a family history of Fragile X related disorders. So this would be things like premature ovarian insufficiency, Fragile X associated ataxia, autism, intellectual disability. And then there's also the option of expanded carrier screening. So as I mentioned, in the world of carrier screening, there are a lot of different options and approaches. Some providers and clinics may take the approach of offering testing only when those certain things are mentioned or met in the previous slide. So only when someone has a certain ancestry will they be offered a hemoglobin electrophoresis. Other clinics and providers may choose to do expanded carrier screening instead, where they're testing each person regardless of their ancestry or whether they have a low MCV for all of those conditions that were previously discussed. And most expanded carrier screening panels includes those conditions that we just covered. Not all of them, but most of them, given that those are such common conditions. However, expanded carrier screening panels can include many more conditions. There are some panels that have up to 300 different conditions that can be assessed for. So one caveat to carrier screening or expanded carrier screening, or at least consideration, is that the more conditions that are being tested for, the more likely that a person will become positive and be a carrier of at least something. Because as humans, we are all carriers of maybe 4 or 5 genetic conditions. So if that many conditions are being assessed, well, it's likely that there will be a positive result. And so really it's important to make sure that a partner is available for testing when so many genes are being looked at to be able to provide, accurate risk assessments for that pregnancy or future pregnancies. Another note about expanded carrier screening, kind of a positive about it, is that on average, most labs are going to be doing sequencing of a gene, which will help with increasing detection rates. Whereas a lot of times if you're testing for just one condition or 2 conditions, there actually might be a mutation analysis that's performed. So what I mean by that is for each gene, so let's talk about cystic fibrosis for this example. So cystic fibrosis is caused by the CFTR gene not functioning. So we all have 2 copies of the CFTR gene, but if there is a mutation or pathogenic variant in that gene that causes it not to work anymore, and it's in both copies, well, that is what's causing cystic fibrosis. And what we know about this gene at this time is that there are about 1,800 different pathogenic variants or reasons why that gene may not be working. And so with sequencing of that gene, what that would mean is that the lab is looking at all of those possible reasons. So all of those currently known about pathogenic variants at the time of testing being performed. So it has pretty good detection rates, because if that person had one of those pathogenic variants, it's very likely that that carrier screening would pick it up. However, when testing for single conditions, so if you were just testing for cystic fibrosis and didn't include it in an expanded carrier screen, it might be assessed by mutation analysis. Mutation analysis is where only a few of the most common pathogenic variants are tested for. And that's what these numbers in this page are illustrating. So ACOG recommends that at least 23 of the most common variants are being assessed when doing cystic fibrosis carrier screening. Some labs will look at more, like 36 or 96 or even 600 of those variants to try and increase their detection rates. But what makes this challenging is that for a person, if let's say they have a family member with cystic fibrosis, well, if they're only being tested for some of the most common variants, they may not be being tested for their familial variant. So if their family member had one of the lesser known variants that can cause cystic fibrosis, and the person is actually tested for only the more common ones, their results might come back as negative, but that doesn't necessarily mean that they are negative for their family's variant. They just weren't tested for it. So with expanded carrier screening, one benefit is that on average, they're going to be doing sequencing of the gene, which certainly helps with some of these issues that I just mentioned. And this is a picture from LabCorp, or a result from LabCorp, to illustrate the point that when only a couple of mutations are assessed, which this result lists all those mutations that were analyzed, so about 36. And of those, if someone comes from an Ashkenazi Jewish ancestry, well, the detection rate for this is 97%, meaning that 97% of the time, if a person from an Ashkenazi Jewish background is a carrier, this testing would pick it up. But as you see with the different ancestries or ethnicities, that detection rate goes much, much lower in those other categories. And the reason for that is not because cystic fibrosis does not occur in those ancestries, rather it may be more of a rarer variant that is causing the cystic fibrosis, or what was previously thought to be more of a rare variant. At this point, we'll transition into diagnostic testing. So as you all may be very familiar, there are 2 main diagnostic testing options. So there's the amniocentesis, which begins roughly about 16 weeks of pregnancy. And then there's the chorionic villi sampling, or CVS, which is done in the first trimester of pregnancy. And when these samples are obtained from each of those diagnostic procedures, there are quite a few different testing options that can be done on those samples. So as we've been discussing multiple screens, so there's aneuploidy screening. So should any of those screens come back positive, diagnostic testing would be available to actually verify those results, whether that's through a karyotype or FISH analysis. And then for the carrier screening, in the event a couple are identified as carriers, then amniocentesis or CVS can be performed in pregnancy to test for those conditions when they are known about. One just plug in terms of one of the later or latest tests that is available to test with those samples obtained from those diagnostic procedures is the microarray analysis. This is now being recommended as the primary test for patients that are undergoing prenatal diagnosis testing. And the reason for that is because this does cover a lot of what a karyotype can do. So it is able to count the chromosomes to detect if there's any aneuploidies, such as Down syndrome or trisomy 18, but it also takes it a little bit further and it's able to zoom in onto the chromosomes to see if little pieces could be missing or extra, so deletions or duplications. And as we've already discussed, microdeletions, even though it's just a few genes that might be deleted, or duplications where it'd be a couple of extra genes, that still can be very impactful for a person. So that still can impact intellect as well as cause birth defects. So this microarray is able to pick up on these smaller deletions and duplications that a karyotype would not be able to, and that's why this is being recommended as the primary test. This is also particularly helpful in cases of miscarriage because a microarray can be done on products of conception. A karyotype can be done as well, however, it only returns a result about half of the time because a karyotype requires living and dividing cells in order to create that picture that we're used to. And that's because those cells are arrested in the metaphase stage. Whereas for a microarray, it does not need growing and dividing cells to do the testing. It can just extract DNA and be able to provide a result. So it's particularly helpful for those cases of miscarriage. As with everything, however, there are limitations of this microarray test, one of which is actually in genetics, we are not familiar with every single deletion or duplication that can exist. So we are not always confident in terms of whether that deletion or duplication actually causes birth defects or intellectual disability. So there are some variants of uncertain significance. So these would be a deletion or duplication that at this time in genetics, we do not know its implications. So there's a chance of a VUS in the setting of a microarray. A microarray also cannot identify structural rearrangements, but a karyotype would be able to. So if someone had a balance rearrangement or translocation, a microarray would not be able to pick that up, whereas a karyotype can. And so to pull everything together, because we certainly covered quite a few different things, I do have a case to present. So this is a patient that came to me because she had a positive quad screen for trisomy 18. So as you see in this picture here, her risk was quoted to be greater than 1 in 10. So when she came to me, in terms of our discussion of the options available to her, we covered that she could consider cell-free DNA screening if she would want another non-invasive option, or she could consider amniocentesis. Given this is a quad screen, this was done in the second trimester, a CVS would not be possible for her at that time. And anytime in looking at a quad screen and that's positive for trisomy 18, it's really helpful just to double check those analytes, which I've underlined in this picture here. So the AFP, estriol, and HCG, just checking to make sure that those are all low, because that's the consistent pattern for a positive trisomy 18 result. And so the patient was really uncertain of how she wanted to proceed. She was leaning towards the cell-free DNA screening because it was non-invasive, but she also very much just wanted to know, does her baby have this condition, or does the baby have this condition? And so at this point, we were discussing, well, with ultrasound, what we know about this condition is that 80 to 90% of the time, or ultrasound has an 80 to 90% detection rate for this condition because we expect multiple birth defects for a baby. And there are particular birth defects that we expect to see when a baby has trisomy 18. So she ended up using ultrasound to help her with her decision making. Unfortunately, ultrasound did reveal multiple birth defects. So a Danzy-Walker variant, a VSD, and other features were identified. So that led her to proceed with an amniocentesis. This is the results of the FISH, or fluorescence in situ hybridization results. And what was identified was that the baby did have triploidy. And then with every FISH result, it is imperative to confirm that with a diagnostic result, which we did through a karyotype. And so the karyotype, as you see in this picture here, is revealing that extra chromosome for each pair, which is what triploidy is. And so this was the result. And what we actually know about triploidy for quad screens is that I noted that when those values are low, that indicates trisomy 18, but that also can indicate triploidy. Even though the quad screen isn't necessarily validated for triploidy, sometimes that can indicate this condition here. And so had we gone or proceeded with cell-free DNA screening, there's a possibility that that result would have come back negative. And so she would have been under the, impression that the baby didn't have trisomy 18 or possibly not a chromosomal abnormality, whereas in fact the baby very much did. Now, other than that other cell-free DNA screen that we described that uses that SNP-based methodology, most cell-free DNA screens probably would not have picked this up, but that one company, that one methodology very well likely would have. But with cell-free DNA screening, a lot of times providers and clinics will choose maybe one lab that they mostly are utilizing. And so if it happened to not be that one lab that uses SNP-based methodology, possibly it could have been missed. And then I do just really want to quickly go over the utility of family history, given this is something that every genetic counselor is offering in their sessions, because of how helpful it can be. So the utility of a family history, there are a couple of different reasons why they are being taken. One reason is actually just to build rapport with a patient. A patient is now sitting in the driver's seat. They are the experts in regards to their family history. So a lot of times it's actually very nice to share this information and to hear from your patient, for them to describe their families. You get to know, how many siblings they have. You get to learn about their other children. But kind of other utilities for family history is that it's helpful for risk assessment. So if somebody had a family history or family member with cystic fibrosis, well, you now know that that patient is not at the population risk to be a carrier for cystic fibrosis. Now they are at a higher risk to be a carrier for cystic fibrosis given that family history. So you know that maybe there's a little bit more reason to be offering that cystic fibrosis carrier screening test, or yet another reason to present to your patient. Another reason that family history is taken is to help with differential diagnosis. So if a baby is identified to have a birth defect through ultrasounds, and asking about the health of other relatives, or if there's other family members who have some features of a genetic condition, sometimes you can piece these things together and maybe have a particular genetic condition that seems to fit with the family history and with the birth defect identified for the baby. And then also it's helpful to provide additional recommendations. So in taking a family history, information such as family history of autism or Duchenne muscular dystrophy may be revealed. Or if someone's had multiple miscarriages, to offer a chromosomal analysis through karyotype for them to try and see if they could have a translocation. So the family history can let you know if there's other things to consider for that patient. And this is just a picture of a family history that I took of a patient of mine, a very impressive family history for Fragile X. So going back to ACOG's recommendations, when there's a family history of somebody with autism or intellectual disability, certainly offering Fragile X carrier screening would be appropriate. And I just wanted to walk through this family history because my patient was actually the person whose the arrow is orange. So she was my patient, but let's pretend her daughter came in for pregnancy testing. And because her daughter, let's say she mentioned, oh, I have a distant relative with autism or Fragile X. As you see, the person that's with the blue arrow, that's the only person in this family history that has Fragile X. And that person in blue is actually a very distant relative to our pretend patient. So a lot of times people might have the knee-jerk reaction to say, oh, this is a very distant relative. This is like a third degree or third cousin potentially. It's probably very unlikely that this would impact your reproduction. But actually, with this family history, this patient, this pretend patient of ours, she has a 50% chance to be a carrier of Fragile X because technically the patient that came to my office, or our pretend patient's mother, is a carrier of Fragile X. So she actually has that 50% risk to also be a carrier. So it actually very much is impactful and meaningful for her reproduction. And so another really key thing with prenatal clinics is collaboration. So again, nothing that we do is in isolation. We are always working together, certainly with the ultrasound technicians, maternal fetal medicine specialists, OBGYNs, genetic counselors, and midwives. So at this point, what we'll actually do is transition into doing a role play to illustrate just how collaborative we can be with one another.
Okay, I am unmuted and we can go ahead with our role play.
Excellent.
So I'm going to be the midwife since that's what I am, and Kim is going to be a genetic counselor that I'm consulting for a patient that I'm doing a prenatal visit with, and the patient has a history of trisomy 21. So this patient is a 35-year-old, and I'm going to go ahead and pretend to call Kim and give her kind of the rundown and see what her recommendations are, because it's the end of my clinic day and I was wanting to provide good information to my patient. So, hi Kim.
Hey there.
I've got a question for you. I think it's fairly straightforward. It just kind of gave me a little bit of a loop, though. She is a 35-year-old G3P1. She's currently 17 weeks and 3 days. Um, Really straightforward history. She did have one early pregnancy loss. She thinks she was about 6 weeks gestational age. But she's also got a child that does have trisomy 21. She had that baby when she was 31, and she's really, really freaked out about the fact that she's had a prior loss and that she's got a previous pregnancy with a confirmed trisomy 21 diagnosis. And, we talked about it. I'm not really helping to allay her fears much. I was just wanted to see, if there's some more information that we could give her, or if maybe she should come in to see you, what we could do for her.
Yeah, definitely. Thank you so much for giving me the call. Some of the things that you're noting, I have a couple of follow-up questions to really help with what the answer is, or kind of what some of these chances are for her to have another pregnancy with a chromosomal aneuploidy, such as Down syndrome. So for her kiddo who has Down syndrome, do they have the testing that confirms this? Does it show that the Down syndrome was secondary to non-disjunction? Is that something that she might have access to?
She's got great documentation. I did not know to ask her that. So it's definitely something I can ask her.
Yeah, perfect. Yeah, because if it shows that there's truly an entire extra chromosome 21, that would indicate to us that truly, this conception or that pregnancy just happened to inherit that extra 21. It's not really something that we think was going to happen more often in each pregnancy. So it really just probably was by chance. And so thinking about this pregnancy and future pregnancies, her risk may be a little bit greater than her age-related risk just because she has this history, but I by no means would be quoting something like a 25% chance if her previous kiddo, truly has Down syndrome by non-disjunction. Now, however, if her child has Down syndrome and it's more due to a translocation, then that's something that, I would recommend having testing for herself and the partner or whomever she had her child with, because this might be something that I would say the reoccurrence risk could be a little bit greater. So really having that distinction will be helpful to really identify what her risks now.
Okay, that makes perfect sense to me. It's something I can definitely talk to her about. And we'll let you know if we need you any further.
All right, sounds good.
Okay, thanks. All right, and we have a second scenario that is similar that I'm going to give Kim a call on, because while it's a similar scenario, there are some distinct differences that Kim and I are going to want to discuss. So, hey, Kim.
Hey there.
I am giving you a call. I've got a patient and she's 35. She's a G7P1. She had 5 early losses. She was about 6 to 8 weeks with all of them. And her one living child does have trisomy 21. She's 17 weeks and 3 days. This just to me, it seems like there's something going on. I want to give her the right information about what we can do for her testing options, screening options. What can we offer her?
Yeah. Again, thanks for the call. And what makes this distinctly different is that, having those 5 early pregnancy losses, this indicates to me that there's a chance that either her or her partner could have a balanced translocation or balanced rearrangement, also called a translocation. So this is where an individual definitely has the correct number of chromosomes. Obviously, they are healthy individuals, but those chromosomes could be rearranged in a way such that when they conceive a pregnancy, pregnancy, that person may accidentally be giving too many or too few chromosomes, thus resulting in a miscarriage because of how important having that total 46 chromosomes can be. So given this history here, two things. One, just like with our last case, for her one current living child, again, is there a karyotype to confirm whether this extra chromosome 21 comes from non-disjunction, or if it illustrates or lets us know about a possible imbalance or inherited imbalance. So that's kind of one step that I would take. But also regardless of those results, so let's say for this one child, they have Down syndrome, again, from non-disjunction by chance, I would still proceed with chromosome analysis of both members of the couple because of those 5 early pregnancy losses. So it wouldn't be out of the realms of possibilities that those 5 pregnancy losses are because of one member having a rearrangement, and maybe just totally separately, they have a child with Down syndrome even due to non-disjunction. So that's not out of the realms of possibility. So I would proceed with both of those kind of approaches. So checking in on her current living child, how was that extra chromosome 21 presented? Was it non-disjunction or not? As well as chromosome analysis. And I think that will then help with deciding what other testing to recommend or offer. So if there is a translocation for one member of the couple, it's important to know what chromosomes are involved because that will then impact whether cell-free DNA screening is going to be helpful or not. Because if those chromosomes that are impacted are maybe chromosomes 1 and 3, well, cell-free DNA testing is not evaluating chromosomes 1 and 3. And so a negative result would likely occur, but it wouldn't really give us any information about the translocation or the chromosomes of concern. So really, there might be a cell-free DNA product that could be helpful. There is kind of a whole genome cell-free DNA product. And so for this patient, that might be more appropriate to offer if she has a translocation or her partner has a translocation impacting other chromosomes that are not routinely assessed with the typical cell-free DNA screen.
Okay, that all makes good sense. I'll probably have her come see you.
Yeah, that'd be great. I'd love to see her.
Great. All right, and we have one more role play to consider. This is a consultation for a rare genetic disorder, something that we don't come across in our everyday clinical activities. We don't necessarily ever even come across in school. It's definitely an interesting case. So, hey, Kim.
Hey there.
I've got a case that I need some consultation on. I've never heard of this before, so hopefully you'll be able to help me out. I've got a 34-year-old. She's a G6P5. She's about 8 weeks. She has a really, really normal obstetric history. She's got no history of miscarriage, but she does have, her 5th child has a rare genetic disorder. It's called GATA-D2B associated neurodevelopmental disorder. And the kid is pretty affected apparently. He was diagnosed at 26 months of age by a whole exome sequence and presents with like a global developmental delay, really limited speech, both expressive and receptive, some infantile hypotonia, and some seizures. Mom says they're just febrile seizures. I looked up the gene and it does associate seizures with the disorder, but I've never heard of this. She is really freaked out. And I'm not sure what to do since I've never heard of this. And it's, yeah, so what's your recommendation?
Yeah. Again, thanks for the call. And quite literally, this condition here, is something I've never heard of. So I will have to do some research. And with genetic conditions, there are thousands upon thousands. So in giving a call to a genetic counselor, sometimes they will not have heard of that condition, and that's totally fine. We have ways to look these things up. And so one location that we look things up is off of Gene Reviews. This is an excellent resource to learn more about reoccurrence risks as well as just features of the condition. So this is what I did in this role play, and I looked this up in Gene Reviews. And so for this patient, it's certainly understandable for her to be freaked out. Up until that point for her kiddos, they haven't had any conditions. And that is something that is reassuring to hear from. Now, from this reoccurrence risk, some of the things to consider is that most of these conditions, or most of the time for this condition, this happens by chance. So thought to be de novo, or just really at that moment of conception. So usually not something that is thought or predicted to be, going to happen for a future pregnancy. And that's the case for a lot of genetic conditions. However, there is the concept called germline mosaicism, which means that for the patient, while she does not have this condition, obviously she does not have these features, it's actually something that could be just in her gonads or just in her egg cells, where this gene, there may be this mutation or variant that causes this gene not to work in the way it's supposed to. So it's not going to have an impact on her, but for 50% of her pregnancies that she conceives, it could have this mutation and could have this condition. I would say this is probably not likely in her case, given she's had 4 otherwise healthy children, and the inheritance of this condition is predicted to be autosomal dominant. So kind of a 50-50 chance. I would predict probably at least one other of her children would have this condition. It's not out of the realms of possibility, however. She may have just fallen kind of on the luckier side of the coin flip. And so it still would be appropriate to offer amniocentesis if she's very anxious about this. Again, I don't think that she would have germline mosaicism given this history, but it's still possible, and this has been reported for this particular genetic condition. So an amniocentesis or a CVS, since that she's a little bit earlier in pregnancy, can be considered.
Okay, great. I'll let her know that those are her options, and I'll send her over to you guys.
Excellent. Awesome. Thank you. Alrighty, and so that concludes our little role play session, but we did want to end on resources for patients. So yet another role of a genetic counselor is kind of all those things that we just discussed. So a genetic counselor does review testing options available to patients, works in collaboration with other providers, takes a family history, but we also provide resources for patients. So a lot of our patients are being diagnosed, or our patients' children or pregnancies are being diagnosed with these conditions. So we don't want to leave them without information as to what to expect once their child is born, because a lot of our patients do continue pregnancy. This information is not always just for, choosing whether to terminate a pregnancy or not. Of course, that is an option, but some people, do plan to continue a pregnancy. So these are some of the resources that we provide. So like downsyndromepregnancy.org, as well as some support for those who do choose to terminate a pregnancy. Those 2 links are really great websites that are certainly very understandable and wonderful to provide to patients. So kind of another thing that we do as a genetic counselor. So just want to make sure you guys had access to those links as well. And then ending on our references, and just again, a big old thanks to you guys for going through this whole webinar and doing our survey. So we do have another session set up for you that Rebecca's going to take on and go into a lot of detail about risk assessment, but also consent, as well as informed consent, in a little bit more detail in that regard. Thank you.
Thank you so much, Kim, and thank you all. And we look forward to the next session. And again, thank you so much for your time.